Today's topic will be management of medical emergencies. Hopefully, we'll talk about the most common emergencies that can happen and how to manage them. Now, we'll talk introduction, vasovagal syncope, hypoglycemic shock, hypersensitivity reaction, angina and MI, adrenal insufficiency, and foreign body aspiration. Now, as an introduction, what can we do to prevent an emergency from happening? Be prepared. Basically, always be prepared. Now, a lot of medical emergencies can happen because of an anxiety, can be provoked by an anxiety, like angina, thyroid storm, myocardial infarction, insulin shock, and so on. These are provoked by anxiety. So, we need to be prepared that if we have a patient, let's say he says, I am diabetic. Okay, I leave something sugary in the clinic, so if hypoglycemic shock happens, I give it to him. If a patient says he had an MI a few years ago or 1 year ago, I will leave some aspirin, nitroglycerin in the clinic. So if I need to give it to him. If it happens, I give it to him. So I need to be prepared always. And I need to know the basic life support. Airway, breathing, circulation, maintain airway, methods to maintain the airway, because until the paramedics arrive to the clinic, I'm alone. Until they come, I'm alone. I need to be able to do the basic life support, the airway, breathing, circulation, and all that. Now we need to teach the staff as well, and we need to take very good medical history. Now, vasovagal syncope is the most common cause of transient loss of consciousness. Now, the basic way how it happens, an anxiety causes increased catecholamines release. This will decrease the peripheral blood the blood vessel vascular resistance. That will reduce the vascular resistance, which would cause pooling of the blood. The blood will go to the peripheries and the extremities. This will cause decreased blood pressure, arterial blood pressure, increasing the heart rate, because once the blood pressure decreases, the body will try to raise the blood pressure to compensate for the lost blood pressure with increasing the heart rate, increasing the respiratory rate. Tachypnea and tachycardia. This will cause more blood to reach the areas. Feeling of warmth, patient will be pale, and so on. Now, this is compensatory mechanism to compensate for the reduced blood pressure. Once everything goes back to normal, there will be decompensation. This will reduce the vagus nerve to mediate bradycardia, bradypnea, hypotension, nausea, and weakness. Now, this will be a much faster process, so it will cause reduced cerebral blood flow to the brain. And this will cause lightheadedness, syncope, and then seizure activity, if prolonged. So, how to manage a patient with vasovagal syncope? Simply terminate the procedure. We need to make the blood go from the peripheries to the brain. So we put the patient in a position where the head is down and the legs are up. The legs are at a level above the brain, so the blood can pull back towards the brain. Once consciousness has been regained, pale, nausea, weakness can be present for several minutes. Then we continue our management or our treatment in the semi-supine or the fully supine position. Now, for the hypoglycemic shock, usually the most common cause of loss of consciousness in patients who are diabetic, it's hypoglycemic shock. This is the most common cause of loss of consciousness. It can happen in healthy patients. That doesn't mean it doesn't happen in healthy patients, but most of the time we see it in diabetics. Now, patients might have excess insulin. He took extra insulin than he's supposed to take. or missed meal. He didn't take a meal, he didn't take breakfast, and he took the insulin. Okay? So that's why these patients we prefer to bring them in the more early morning appointments, so the breakfast and the insulin can still be working and we don't find severe hypoglycemia happening. Now, how to know if the patient has hypoglycemic shock? Now, first, the patient becomes irritable and uncooperative. You tell him, open your mouth, he doesn't open it. You tell him, please let me see, he doesn't allow you to see. He wants to go away, he wants to run. Now, here we suspect irritability and uncooperativeness and confusion. These are due to hypoglycemia. These are the initial symptoms of hypoglycemia. Then patients would be pale, anxious, hunger, nauseated, sweaty, mood changes, tachycardia, and loss of consciousness. So let's say, how can I find if this patient is vasovagal syncope or hypoglycemic shock? How can I find? How can I differentiate between the two? Because they both have the same symptoms. They both have unconsciousness, they both have pale, they both have tachycardia, they both have anxiety. How can I differentiate between the two? Now, first, medical history. If the patient's diabetic, I would suspect more hypoglycemic shock. But also vasovagal syncope can happen. Now, the easier management is we put the patient in the head down, legs up position for about 30 seconds. If the patient gets better and everything goes back to normal, that's vasovagal syncope, we managed it, everything is perfect. If the patient is still unconscious and he tells you it's going worse, then we put the patient back into the normal position, we give him something sugary while he's conscious, and that's hypoglycemic shock. Okay? So, if he's conscious, we give him oral sugary intake. If he's unconscious, we give him 50% dextrose IV or 1 milligram of glucagon IM. No organ dysfunction without other organs being affected, it's hypertensive urgency. If it's with organ dysfunction, it's emergency. Here, the patient should be sent to the ER to reduce the blood pressure. Now, hypersensitivity reaction. Type 1 is the most severe because it can lead to anaphylactic shock. It's an acute life-threatening condition. Now, first, patients would feel like there's impending doom, like something bad is coming, something bad is happening. Then he will start to have loss of consciousness. Before the loss of consciousness, the patient will have respiratory distress, dyspnea, loss of difficulty breathing. Patients might become cyanotic. So the least severe manifestation is skin or mucosal redness. Then total airway obstruction will happen, hypotension because of the peripheral vasodilation and decreasing the cardiac output, and then the patient becomes unconscious. Now, if I have a patient who says, I have never been into the dentist, I have a lot of sensitivity to a lot of things, and I don't know what to do. I'm afraid that I'm allergic to the local anesthetic agent. What can we do is that we can give 0.1 milliliter of the local anesthetic agent. Just 0.1. This will not cause a lot of problems. This will not cause anaphylactic shock. It's very minimal. And then we wait about 10 to 15 minutes. If any symptoms appear, then he's allergic. If no symptoms, he's not allergic. Now, the management, we give IV or IM antihistamines, diphenhydramine or chlorpheniramine, malate, oral antihistamines for 6 to 8 hours for 24 hours post-op, And if it's severe anaphylactic shock, we give zero point 0.3 milliliter of 1 to 1000 epinephrine, followed by antihistamines, IV, either hydrocortisone or dexamethasone. Now, patients might feel, while we're doing the procedure, the patients might feel heavy crushing in nature chest pain, radiating to the shoulder, to the arm, to the neck, to the jaws, all of those. Here we will suspect MI or angina. Now, angina can be stable or unstable. Now, how can we know which one of those is the emergency that we have in the process? We rest the patient, we put him in the supine position, then we give him nitroglycerin sublingually. If the pain goes away by the rest and the nitroglycerin, it's stable angina, we stop. If the pain doesn't go away, then we suspect it's MI. So call medical emergency immediately. Call the ER, 911 to come. After that, we give the patient nitroglycerin sublingually, if we didn't give him already, aspirin 300 milligrams crushed, oxygen, and wait for the ER. Now, for MI, we have a mnemonic called MONA: morphine, oxygen, nitroglycerin, aspirin. These are the 4 medications that should be given. If we have morphine, we can give, but preferably we don't give it. We wait for the 911 to come, give the patient. We tell them what we did. We have a patient with chest pain. After a few minutes of working, he took lidocaine with adrenaline. We gave him aspirin and nitroglycerin and maintained oxygen for him. That's it. Now, seizure can happen as well. Now, seizure can be called fit or convulsion or epilepsy. Patients might be on phenytoin, phenobarbital, or valproic acid. Now, for any patient with epilepsy, to do any procedure for him, we need a signed consultation from the physician telling he is fit for surgery, he's not fit for surgery, he's not fit to do anything under local anesthesia. He's fit to do a lot of things under local anesthesia. Whatever the thing the physician will say. So once we have made sure that everything is in line, the patient took his medication, the patient is in good condition, he's stable to work on him to do endo, to do restorations, to do extractions, whatever it is. Great. Once we give local anesthesia, we do not place our fingers. We place tongue depressors. A lot of tongue depressors, we cover them with tape, and then we let the patient bite on it, and then we give the anesthesia, because if he gets into seizures, he will kind of bite our fingers off. So we place something that he cannot cut. Okay, and then we can do the procedure. Now, continuous or repeated seizures without recovery, it's called status epilepticus, and this is a main emergency. The patient should be sent to the ER. Now, let's say while we're doing the procedure, we're doing endo or extractions, the patient started to have tonic-clonic movement, to start to have stiffness of his muscles and sudden movements and loss of urine control. He started to urinate on himself. What can we do? How to manage this? First, we stop our procedure. Terminate the dental management. Terminate it. It's not important now. Then, we call 911, of course. Place the patient in the supine position and remove any sharp objects around the patient. Remove them. Anything that's sharp that the patient can injure himself with, we put them away. And then we wait until the patient finishes his seizure. The only thing that we can do is jaw thrust to keep the airway patent and prevent the tongue pulling backwards. Now, we wait until the patient finishes his seizure. Now, we suction the airway if necessary. If he is conscious, monitor vital signs, administer oxygen, consult the physician, observe him for 1 hour, and then we can escort him home. If he is unconscious, we summon medical assistance, place the patient on the side and suction the airway, monitor vital signs, initiate basic life support if necessary, administer oxygen, transport to emergency. If it's status epilepticus, diazepam 5 milligram every minute intravenously. Now, patients who come to the dental clinic are stressed, as we said in the beginning of the lecture. So, these stressed patients, if they're healthy, that's fine. If they're not, if they're taking exogenous corticosteroids from external sources like prednisolone, hydrocortisone for whatever disease that they have, here the endogenous corticosteroids will not be released. They will not be secreted in good amounts because the major comes from external sources. Why should we get tired so we can have corticosteroids coming out? He takes it from outside. Why should we bother ourselves? Okay, so they secrete the amount necessary to keep or missing from the exogenous type. Now, we said in the medically compromised lecture that some patients we need to suspect that these patients might need corticosteroid cover before working. And we said we have the rule of two and another rule. Now, the rule of two says if the patient took more or equivalent to 20 milligrams of hydrocortisone, daily for at least 2 weeks within 2 years of dental management. Here we need to give him extra corticosteroids before we start working our procedure. The other rule says if the patient takes about 7.5 or above milligram prednisolone, 4 if the patient is already on it or took it more than a week within the past month or more than a month within the past year. Now, let's say the patient is having adrenal insufficiency. How can I know? There will be abdominal pain, there will be confusion, there will be feeling of extreme fatigue, hypotension, muscle pain, nausea, partial or total loss of consciousness, and weakness. So, to manage it, we terminate dental treatment, monitor the vital signs if he's hypotensive, head down, legs up. We give him oxygen and 100 milligram hydrocortisone, IV or IM, with IV fluids. Now, I do something that it's helpful for me. Whenever I have a patient who takes corticosteroids, even if it's 5 milligrams, if he takes just that, 5 milligrams or more, I always prefer to put an IV access, a cannula. So, if I need anything, if something happens during the procedure, I can have a straight IV access that I can give the patient any drugs that I want. And once we're done, we remove it away. Now, foreign body, sometimes a clamp, a part of a tooth, a file, anything that, an endophile of course, can be passed through to the stomach or to the lungs. Now, how to know if it's in the stomach or in the lungs? Now, if it's in the stomach, the patient will not have any serious symptoms. He will not have coughing, he will not have cyanosis, he will not have any symptoms, he will be fine. And basically that's it, because if it's swallowed, We wait a few days until it goes out in the stool. That's it. If it's respiratory, it can cause blockage of the airway or it can cause partial blockage. So patients will be gasping for air. He will need air as much as he wants. He will try to find air. He will fight for air. Okay? Now, but the patient, if it's blocking the airway, we need to do Helmick maneuvers so we can push it upward to push it more towards the surface before the patient's consciousness is lost. So we can have coughing, we can have cyanosis, we can have loss of consciousness, we can have the patient gasping for air. All those are signs that this piece has been into the airway. And here we need to call the 911 to take the patient for admission and laryngoscopy or bronchoscopy. Now here we can see Helmick maneuver being done to push the piece upwards. And hopefully it's a good lecture and you enjoyed it. If you have any questions, please let me know, and thank you.